Professor Stephen, can you hear me?
Can you also speak? We can hear you well. I can hear you well, but can you also hear me?
Stephen, can you hear me?
Yes.
Okay.
I can.
This is Shabazz from Islamabad, and
Hello.
welcome to the cardio conference here. And we're looking forward to your presentation.
Hello. Can you hear me? That's what I
Yeah, we can hear you, but if you come a little bit closer to the mic, it would be even better.
Okay, that's as close as I can come. I will speak up a little bit. Maybe this is good, huh?
Okay.
So let me just see what I can do so I get my
I think
slides
what you
up.
need to do is to put your camera on. We can't see you, but we can hear you.
Okay, but at the moment, my computer doesn't do anything. So something is completely frozen about this presentation. I'm really sorry, but something is not working at all. And I don't have a good clue what it is. I think the only thing I can do is restart something.
Stefan, if we can have your slides on and your voice, that should be enough.
No, this
Because
really
I'm
do
told
get
that if we would love to have your picture, but if we can't, then because it may become heavy in that case.
Yeah, but the problem is that I'm at the moment not able to operate my computer. I think I will need to restart and reconnect in about 2 minutes. Let's do that because I have no other option here. So give me 2 minutes so I can restart and then I'll be back, okay? We'll do that.
We can start with the program now. Thank you very much, Stefan, to agree to address this cardiocon.
Yes, my pleasure.
Professor Stefan Achenbach is the president-elect of the European Society of Cardiology, and he has made a little promise to me that once he takes over, he's going to bring ESC to Pakistan.
Yes, I hope so. Absolutely. We hope to be good partners in the future.
Yes, sir. Go ahead.
Well, I have been invited to speak to you for the next 25 minutes or so about what has been new in heart failure and chronic coronary syndrome, especially in the context of ESC Congress 2019 in Paris, and it's my pleasure to do so. I would like to start with heart failure and talk about some studies that you've probably already heard about. And there are two major studies which were presented at ESC Congress. Of course, there was lots of smaller science, but the two major studies were Paragon HF and DAPA HF, obviously. And we know one of these studies interestingly addresses patients who have heart failure with preserved ejection fraction. That's the Paragon HF study. And the other one addresses patients with heart failure who have reduced ejection fraction. So it's very interesting to look at these two studies. Let's start with Paragon HF. And you know all that in the last decades or so, cardiologists have understood that there's not only what we typically see as heart failure, the patient who has reduced ejection fraction, LVEF less than 40%, as you can see here, for whatever reason, whether it's myocardial cardiomyopathy or ischemic heart disease. But there's also patients who have heart failure who have better left ventricular ejection fraction. And that we call those with an ejection fraction between 40 and 49%, we call heart failure with mid-range ejection fraction, and those with an ejection fraction of more than 50% we call.
Stefan, can we get the slides on?
Yeah, my slides are on. They should be on. With preserved ejection fraction. Let's see what we can do to get the slides on. Here we go. Now you should see my slides. How is this? Can you see my slides now?
Yeah, we can see your slides now.
Okay. And so here we go. I want to make this really large. Now we see them really nice, I guess.
Very good.
So we have these three types of heart failure: reduced ejection fraction, mid-range, and heart failure with preserved ejection fraction. Now, about 3 years ago, we had a fantastic new insight into treatment of patients with heart failure who have reduced ejection fraction. You've all heard of the PARADIGM study, which used sacubitril valsartan combination in patients who had heart failure with reduced ejection fraction, and how it really impressed us cardiologists because we had a significant improvement in outcome in patients with heart failure because of this combination, sacubitril valsartan. And you can see that the number of needed to treat was very small. Only 21 patients needed to treat for 3 years to reduce one event of cardiovascular death and heart failure hospitalization. Highly significant difference between ACE inhibitor alone and the combination sacubitril valsartan. And also, and this was interesting and most important, a 16% reduction of mortality, absolute reduction of 16%. So this was a fantastic trial in patients who have heart failure with reduced ejection fraction. And the question, of course, is whether this medication, sacubitril valsartan, would also be beneficial in patients who have heart failure with preserved ejection fraction or mid-range ejection fraction. So here's the PARAGON-HF study, which was presented, 4,800 patients who were randomized, followed for approximately 3 years, and you can see that they all had to be included. They had to have an ejection fraction of more than 45%. So to specifically address those who do not have what we call reduced ejection fraction. They had to have some structural heart disease, either left atrial enlargement or left ventricular hypertrophy. Slight elevation of NT-BNP was also required. And then the patients in a relatively complex scheme first had a run-in phase to make sure that they tolerated valsartan well, that they tolerated the combination sacubitril valsartan well, and then these patients who had heart failure with preserved ejection fraction were randomized to either receive sacubitril valsartan or valsartan alone. So this was not against placebo, it was the combination sacubitril valsartan against valsartan alone. And then patients were followed for approximately 3 years. The main outcome was a combination of total heart failure hospitalization and cardiovascular death. So this is an important outcome in heart failure patients, obviously. And you can see that there was a difference, a visible difference between those patients who had valsartan only and had a higher event rate than those patients who had the combination. But the p-value was 0.059. So the result just barely missed the pre-specified significant threshold of 0.05. There was quite a bit of discussion how to interpret this, and the same has been seen for the endpoint of heart failure hospitalizations alone. That significance was just barely missed. So there was a bit of discussion how to interpret this, and whether this is a significant study because it's almost significant, or whether this is not significant because the p-value is 0.056 and 0.059. It did officially miss the pre-specified endpoint, but then in some subgroup analysis, it was shown that in females, there was a significant reduction of events as compared to male patients where no such effect was found. And also interestingly, if patients were stratified according to their ejection fraction, you can see that in those who had the lower 50% of ejection fraction, less than 57% ejection fraction, there was a significant advantage regarding the combined endpoint of using this combination therapy, sacubitril valsartan, while in those with a higher ejection fraction, there was absolutely no effect. So it seems to be that this group is very inhomogeneous, the patients who have heart failure with preserved ejection fraction. There are some who probably have more structural heart disease where the combination therapy was helpful, while some others with almost entirely normal ejection fraction, there was no effect. So there was a lot of discussion about this study. You know, it's an effect, but it's not quite significant in the overall cohort, and then in some subgroups you can find significance. And depending on the expert you talk to, some will say the glass is half full, and others will say the glass is half empty. We missed significance, while the others say we always got significance. So there will still be a lot of discussion around this because some subgroups had some effect, other subgroups did not. The primary endpoint was missed. So the discussion will continue, and we will see what happens. What do the authors say, the authors of this trial say, well, seems to be, and this is reasonable, that patients who have heart failure with preserved ejection fraction are in reality an inhomogeneous group. The underlying pathology is very different. So we need to identify those patients who potentially benefit from this medication. And the conclusion is that this combination sacubitril/valsartan may be beneficial in some patients with heart failure with preserved ejection fraction, and this is probably a reasonable conclusion. The second study, and probably the most important study presented at ESC Congress 2019, and maybe the most important study presented in cardiology in the entire last year, was DAPA-HF. This is not patients with preserved ejection fraction. This is a trial in patients who have reduced ejection fraction. And you've probably heard of this trial, which was presented by John McMurray at ESC Congress 2019 in Paris. Let me move on, here we go. And the background is that there's a group of drugs which have been developed for anti-diabetic treatment, the SGLT2 inhibitors, which inhibit glucose reabsorption in the kidney and lead to an increased excretion of urinary glucose. Now, these drugs were initially designed as anti-diabetic medications, but there is a history. There's a history that some anti-diabetic medications have negative cardiovascular effects. And for this reason, the Food and Drug Administration in the United States requires very extensive safety studies for new drugs which are meant for anti-diabetic treatment. And a number of years ago, the EMPA-REG study was performed. It tested an SGLT2 inhibitor, empagliflozin, in patients who had diabetes regarding their cardiovascular outcomes. But importantly, this trial was designed as a safety trial. The trial was designed to make sure that diabetic patients have no harm when taking these medications. Because for some other drugs, there had been signals that diabetics have increased cardiovascular event rate. So this was a safety trial that was performed to show the safety of empagliflozin in diabetic patients. 7,000 diabetic patients who had diabetes and cardiovascular comorbidities. And almost to the surprise of everybody, this safety trial, which was only meant to show that there was no harm, did show that there was a significant beneficial effect for patients who had diabetes, for example, regarding hospitalizations for heart failure. So this drug, which underwent the safety trial, demonstrated that there was an advantage regarding heart failure hospitalizations in patients with diabetes. And most impressively, cardiovascular death and overall death was also significantly reduced by empagliflozin in this trial, which has been designed initially as a safety trial. So this was very interesting. In diabetic patients, this drug reduces cardiovascular events. Other drugs from the same group showed similar results. That's always encouraging. Canagliflozin, another SGLT2 inhibitor, also showed for a combined endpoint a significant effect in patients who had type 2 diabetes. Not even pre-selected for cardiovascular comorbidity, but in the overall group, there was also a benefit of canagliflozin in diabetic patients on cardiovascular outcome. So now, since this drug reduced heart failure events in diabetic patients, there was the idea of this study group to see whether potentially an SGLT2 inhibitors would potentially be beneficial in patients with heart failure, whether or not they had diabetes. So this is a use of an anti-diabetic drug, originally designed to be an anti-diabetic drug in patients with heart failure, regardless of them being diabetic or not. So this is the background, that this SGLT2 principle, SGLT2 inhibition, has shown that it's useful to prevent the development of heart failure in patients with type 2 diabetes. And the question is whether they can be used to treat patients who have established heart failure. And the trial was designed to include both patients with and without type 2 diabetes. The inclusion criteria for this trial were the presence of symptomatic heart failure, an ejection fraction of less than 40%, and then slightly elevated NT-BNP, and the endpoint was worsening heart failure. That's heart failure hospitalization, unplanned heart failure hospitalization, or also to include cardiovascular death, so heart endpoints. 8,000 patients were screened, 4,700 patients were randomized, half and half assigned to dapagliflozin or placebo. And here's the outcome. Here's the impressive outcome, which impressed everybody at ESC Congress 2019, that for the combined endpoint of death, heart failure hospitalization, and an urgent heart failure visit, there was a highly significant P equals 0.00001 significant benefit of dapagliflozin as compared to placebo. These patients were on good treatment. They had ACE inhibitors, beta blockers, they had on board already, and the additional use of dapagliflozin reduced this combined endpoint significantly. Small number needed to treat, only 21. And most impressively, also all-cause mortality was significantly reduced by this dapagliflozin, the SGLT2 inhibitor, in patients who had heart failure. Now, the most impressive pre-specified subgroup analysis was to look at patients who had diabetes and patients who had no diabetes. And the impressive and very clear finding was that in both groups, whether patients had diabetes, yes, or whether they did not have diabetes, there was a significant benefit of SGLT2 inhibition on outcome in patients with heart failure. So the conclusion of the trial is that in patients who have heart failure and reduced ejection fraction, the risk of heart failure or death from cardiovascular causes was lower among those who received dapagliflozin, and this was regardless of the presence or absence of diabetes. So this is an entirely new principle that we might potentially be using in the future to treat patients with heart failure completely independent from the fact whether they have diabetes or not. And this was, of course, received with tremendous interest and even spontaneous applause during the presentation when this was presented in Paris in August 2019. And we will certainly see more trials that show the same effect for other SGLT2 inhibitors, and we can expect this to become a new and additional treatment principle, SGLT2 inhibition, in patients with heart failure, no matter whether they have diabetes or not. The second big topic of my talk, I've been asked to cover chronic coronary syndromes, and I want to limit myself to the new guideline that was published by the ESC on chronic coronary syndromes, because there are some changes which are quite significant, and they include mainly the new names. This used to be the guideline for stable coronary disease, which is now called the guideline for chronic coronary syndromes. There is some change in diagnostic pathways, which diagnostic tests to use, not so much change in revascularization and medical therapy. So why was the name changed from stable coronary artery disease to chronic coronary syndrome? Well, this was done to specifically highlight the fact that patients who have coronary artery disease will never be completely stable or entirely healed. Here's an example of a patient who has a stenosis in the left circumflex coronary artery. This stenosis can be treated, and we typically would refer to this as stable coronary disease. However, we all know that these patients come back. The patients come back with acute coronary syndromes, here an occlusion of the left anterior descending coronary artery. So these are not patients who require no further care, as the name stable coronary artery disease might suggest. And this is why the task force decided to change the name of the guideline into the guideline for chronic coronary syndromes, reflecting the fact that these patients need chronic care rather than the previous term stable coronary artery disease. Regarding the diagnostic pathways, how do we diagnose patients with suspected stable coronary artery disease? There has also been a significant change. In previous guidelines in 2013, there was a class 1 recommendation for ischemia testing, stress echo, stress myocardial perfusion, and stress magnetic resonance imaging. These are the class 1, the recommended tests in patients who have suspected coronary artery disease. That was in 2013. And there was also a class 1B recommendation for the exercise EKG, which we all know performs not quite as well, but which of course is widely used because it is cheap and widely available. And then there was a class 2A recommendation should be considered for coronary CT angiography, but the main recommendation was to use stress ischemia imaging first. Now this has changed. In the new guidelines published in 2019, also in Paris at the Congress, now there is this graph that illustrates that in patients who have very low pretest likelihood, no testing is necessary at all. This is the young woman with very atypical chest pain. In patients with very high pretest likelihood, it might be reasonable to start immediately with invasive angiography combined with fractional flow reserve. However, in the large group of patients with an intermediate pretest likelihood of obstructive coronary artery disease, there is now equal mentioning of ischemia testing, stress echo, stress MR, myocardial perfusion imaging, and coronary CT angiography. And the choice of which of these to use should be made based on clinical characteristics of the patients, availability, local expertise, but basically CT angiography is now recommended with the same level and the same priority as ischemia testing, and this is an entirely new aspect. And we all know that coronary CT angiography has improved tremendously over the past several years. You can see stenosis. We can see clearly when there are no stenosis, image quality is in many cases very, very impressive. And this is why this has been upgraded to be a class 1 recommendation. And this is backed by a number of large trials. The PROMISE trial, which has randomized 10,000 patients with suspected coronary disease to receive either CTA, coronary CT, or myocardial perfusion imaging as the first test, and the outcome was completely identical. So no downside of using coronary CT angiography as compared to stress testing. And the Scotch Heart trial, which randomized 4,000 patients with suspected coronary artery disease to either have the standard of care workup, ischemia testing, or the standard of care plus, in addition, coronary CTA. And it was in fact, even able to show a small improvement in the outcome of myocardial infarction in those who had coronary CTA in addition to standard testing. So a slight reduction in the rate of myocardial infarctions. I would like to personally add that I'm very happy that I see now coronary CT angiography to be upgraded to be a class 1 recommendation, so something that we can use in patients with suspected coronary disease. But I would like to highlight what the guideline also emphasizes, that image quality has to be good. In patients with good image quality, coronary CTA is fantastic and it can provide very reliable diagnostic assessment. While if image quality is poor, patients are poorly prepared, the scan is not done very well, then images are typically very unreliable and not useful for clinical decision making. So image quality is absolutely key in coronary CT angiography. So the guidelines now say that there's a class 1 recommendation in patients with suspected coronary disease to use either coronary CT angiography or imaging for myocardial ischemia, stress echo, stress MR, myocardial perfusion, and so on. The selection of this first test should be done based on the clinical likelihood of coronary disease and other patient characteristics that perform test performance. And this is what I just said, image quality is important. So we should use the test for which the patient is suited. Coronary CTA, for example, typically requires a regular heart rate, sinus rhythm, relatively low heart rate. So these are the patients who should go to coronary CTA. Local expertise should also be considered, and the availability, of course, should also be considered. The exercise EKG is used a lot in many countries, including my country, Germany, to work up patients with suspected coronary disease. There is still a class 1 recommendation, but it's a level of C, so it's a consensus recommendation that mainly exercise EKG should be recommended to assess exercise tolerance. We all know that to identify ischemia, exercise EKG is not very reliable. So this comes back to the central illustration that in patients with suspected coronary artery disease, the preference is to use either coronary CTA or imaging tests for ischemia, such as stress echo, myocardial perfusion, or echocardiography. And here's a flow chart that says if you have a low clinical likelihood and the patient characteristics suggest high image quality, then consider CT angiography as the first test. If the clinical likelihood is relatively high, revascularization is likely, you also want to know about viability potentially, then consider imaging tests for ischemia. And in some patients, like those who have very high clinical likelihood, very typical symptoms, and potentially also left ventricular dysfunction, potentially it might be best to go immediately on to invasive angiography. However, then be ready to do functional assessment, FFR measurements, if you see a lesion to make sure that they're really correct. Revascularization is pretty much unchanged as compared to previous guidelines. Revascularization is indicated when ischemia is present. If the diameter stenosis is more than 90%, you can assume that ischemia is present. And in asymptomatic individuals, you should only revascularize if ischemia testing, either non-invasive or by FFR, suggests that there's more than 10% of the left ventricle which is ischemic. Finally, on work on medication, I don't think we have to discuss anti-anginal medication a lot. The first-line drugs are beta blockers and calcium channel blockers, and they can be complemented with other drugs if necessary. And depending on the situation, whether you have a high heart rate, a low heart rate, low blood pressure, left ventricular dysfunction, there are different pathways which are suggested in this guideline. One major change, and this is the last point I would like to make, is the lipid targets in patients who have established coronary artery disease. They have been made even more strict than they used to be. In the chronic coronary syndrome guidelines and also in the guidelines which were published regarding dyslipidemias, now for patients who have established coronary artery disease, the recommendation is to even go to an LDL cholesterol level of 55 milligrams per deciliter. This used to be 70 milligrams, and now the new recommendation is to try to achieve 55 milligrams per deciliter to reduce event rates in patients who have established coronary artery disease. So the new aspects patients. Sorry, now my presentation, I have to move quickly, go back to the slide. Somehow this has jumped back. Here we go. The new aspects in the guideline for chronic coronary syndromes is the new name, chronic coronary syndrome, to express that continuous care is necessary. The fact that diagnostic testing should include the use of CT and should be picked according to patient characteristics and local expertise, and importantly, the lowering of the LDL cholesterol recommended now to try and achieve 55 milligrams per deciliter. And with that, I would like to thank you very much for your attention. A lot of more information can be found on the ESC website, www.cardiocon.org. Thank you very much, and I hope that one day I'll be able to come to Pakistan personally.
Thank you very much, Professor Stefan, for an excellent presentation both on heart failure management and the management of chronic coronary syndrome. Can we have a couple of questions from you?
Absolutely. I'd be happy to answer questions.
Sir. In the management of patients with heart failure, what is the role for intravenous iron? And when do you propose, and what are the tests that you propose for it? We'll just have one question.
Intravenous iron is mentioned in the heart failure guidelines for symptomatic improvement. And in fact, in Europe, it is used rather extensively. In patients who have iron deficiency, and this is not necessarily tied to anemia, you can have normal hemoglobin values and still have iron deficiency. There are several trials which have shown symptomatic benefit of intravenous iron. There is no benefit of oral iron. We all know how difficult it is. But for intravenous iron, there has been shown symptomatic benefit in heart failure patients. So there's a class 2A recommendation. It should be considered if there's iron deficiency. We typically measure here the transferrin saturation values, which is the most reliable indicator of iron deficiency. The background is that mitochondria in the cells need iron to work. So muscles, including the heart muscle, need iron to generate energy and contractility, and this is why iron substitution is important. It has nothing to do with anemia, but currently only for symptomatic improvement with the class 2A recommendation if there is iron deficiency. There are studies going on with mortality as the targeted outcome, and it will be interesting to see what the result is, but currently not for mortality.
Thank you very much, Professor Stefan, for giving us your valuable time And
Certainly.
we sincerely hope to have more cooperation with you in future. Thank you from
Thank you.
myself
It's a
and from
pleasure-
the entire
pleasure to talk to
cardiology
you.
community sitting here. Thank you, sir.
Thank you. Thanks a lot.